In today's lecture, we're going to be talking about glucocorticoids in relationship to non-endocrine disorders. Do you remember what organ produces corticosteroids in our body? The adrenal cortex produces the endogenous corticosteroids, and this includes the two different subclasses. It also includes the mineralocorticoids, which modulate salt and water balance, and also the glucocorticoids, which we're going to be talking more extensively here. And it influences carbohydrate metabolism and other processes, which we're going to talk about. Glucocorticoid drugs are nearly identical to the glucose regulating steroids that are produced by our adrenal cortex. So it is a good form of a synthetic version of glucocorticoid. And we look to these drugs as having two kinds of effects. We're either looking to produce a physiologic effect or a pharmacologic effect. So, in terms of physiologic effects, we're trying to think about the maintenance of our normal physiologic function. So, this can be elicited when we are providing our patients with very low doses of glucocorticoids. However, to contrast that, to achieve a pharmacologic effect, we really need to have higher doses. And why would we use a higher dose? Think about for the treatment of inflammatory disorders, for instance. We learned about inhaled glucocorticoids for the use of treating asthma. We also can use oral forms for the use of treating rheumatoid arthritis and other cancers, certain cancers as well. And the problem with high dose pharmacological treatment, though, is that we have the adverse effect of immune suppression and response as well. And this is higher even in organ transplant recipients. Now, glucocorticoids themselves, they're devoid of toxicity when we're using it in physiologic doses. Remember, these are the lower doses. However, if we're using high doses and we're using it for extended periods of time, there are a variety of serious adverse effects. So, this is a lecture that we're going to be discussing what those adverse effects are as well. Now, because there are similarities among drugs within this class, the glucocorticoids, there's more similarities than differences. We're not going to break them down into specific glucocorticoid drugs, but we're going to talk about them in terms of being a prototypical agent. So when we say glucocorticoids, we're talking about the whole group of glucocorticoids in this class. Glucocorticoids play many roles in our overall physiology, but first we're going to start with just the role or the effect it has on our metabolism. In terms of carbohydrate metabolism, the principal effect is going to be the elevation of blood glucose. Glucocorticoids do this by promoting the synthesis of glucose from our amino acids and our lipids. It reduces peripheral glucose utilization and reduces the glucose uptake by our muscles and adipose tissue. So the net effect is going to be increased blood glucose. Glucocorticoids also promote the storage of glucose in the form of glycogen in our body. These drugs have a negative effect on protein metabolism. Specifically, the drugs will suppress the synthesis of proteins from amino acids and divert those amino acids for the production of more glucose. And the most consistent effect of glucocorticoids on fat metabolism is the stimulation of fat breakdown or lipolysis. Glucocorticoids also play an important role in the physiology of our cardiovascular system. They are required to help maintain the functional integrity of the vascular system. And when levels of our endogenous glucocorticoids are low, capillaries become more permeable and vasoconstriction is suppressed, and it can cause blood pressure to fall. They also have a pretty interesting effect on our blood cells directly. They can increase the number of circulating RBCs and neutrophils. To contrast this, though, the decreased counts of lymphocytes and eosinophils and basophils and monocytes can be found due to glucocorticoids. Within our central nervous system, glucocorticoids have an essential role in the CNS function um, in terms of neural excitability. Whenever we have the mechanics, this homeostatic mechanic disrupted within our CNS, lower glucocorticoid levels can cause depression, and higher levels can also cause mania or excitation. In times of physiologic stress, like infection or trauma, or even undergoing a surgical procedure, our adrenal glands will secrete a larger amount of glucocorticoids as well as epinephrine. So, together, both of these hormones are going to help maintain blood pressure and blood glucose levels. If glucocorticoids are released in an insufficient amount, however, then we may be prone to hypotension and hypoglycemia. In terms of very, very severe stress, glucocorticoid insufficiency can actually result in death due to circulatory failure. Glucocorticoids also play a role in our maintenance of fluid and electrolytes. Individual glucocorticoids can actually exert actions that are very similar to aldosterone to varying degrees, depending on the glucocorticoid. And aldosterone is released by the adrenal glands. So, when the glucocorticoids act on the kidney to promote the retention of sodium water, this will also increase excretion of potassium. So, the net result may be hypernatremia with hypokalemia and edema on assessment. In terms of neonatal respiratory system, during labor and delivery, the adrenal glands of a full term infant can release a burst of hormone, glucocorticoid. And this is going to act to mature the lungs. And in a preterm infant, the production, though, of glucocorticoids is still low. And this is one of the issues that points to the high incidence of respiratory distress syndrome. And many times in the treatment of preterm infants, they may be given glucocorticoids to help hasten the maturity of the lungs. So, going back to patho for a second, remembering that the synthesis and the release of glucocorticoids are regulated by a negative feedback loop. So, the principal components of this loop are going to start with the hypothalamus, the anterior pituitary, and the adrenal cortex. So, those are the three main organs. The loop is turned on whenever we are under stress or there's another stimulus that is coming from the CNS. Once we get that stimulus, it may act on the hypothalamus, which then causes the release of CRH. And CRH is corticotropin releasing hormone. This is going to stimulate now the pituitary, specifically to release ACTH, which is adrenocorticotropic hormone. This then will act on the adrenal gland, the adrenal cortex specifically, to promote the synthesis and the release of cortisol. And cortisol is the principal endogenous form of glucocorticoid. Cortisol itself has two basic effects. It can stimulate our physiologic responses, but also it acts on the hypothalamus and the pituitary to suppress further release of CRH and ACTH, saying that we have enough. When we're inhibiting the release of corticotropin releasing hormone and adrenocorticotropic hormone, CRH and ATH, the cortisol suppresses its own production as well. When glucocorticoids are given in chronic and large doses, this feedback loop is going to continually be suppressed. And we're going to see in one of the last slides of this lecture how that persistent suppression can be dangerous to our patient. Now we're going to look at the mechanism of action and really be able to differentiate that glucocorticoids are different from most other drugs in two different ways. The glucocorticoid receptors are located inside the cell rather than on a cell surface. They also modulate the production of regulatory proteins rather than just the activity of the signaling pathway itself. So, this is how we do it. First, glucocorticoids are going to penetrate the membrane. And remember, it's not just going to live on the surface, it's going to go right inside. It's going to bind to the receptor inside the cytoplasm, converts that receptor from an inactive form to an active form of receptor. Then the receptor, now being a steroid complex, will migrate to the nucleus of the cell, and it's going to bind to chromatin within the DNA. By doing this, it's going to alter the activity of the target genes, and in most cases, the activity of the target gene will become increased. This increased DNA activity will also increase the transcription of messenger RNA molecules, and these code for regulatory proteins. Yet in some cases, the activity of the target gene becomes suppressed, and the synthesis of certain regulatory proteins will then decline. High doses of glucocorticoids can actually cause effects on metabolism and electrolytes. With high doses, in terms of your electrolytes, you can actually cause significant sodium retention, so hypernatremia, or potassium loss, or hypokalemia. Additionally, high dose therapy can also inhibit the absorption of calcium in your intestines. So you may also be left with less absorption there. The effects of high dose therapy on your metabolism has to do with the rise of glucose and the suppression of protein synthesis. Remembering also that fat deposits become mobilized. But just remember that this is going to have a rather small or little effect on this. We're using glucocorticoids majorly for the application of an immune response and inflammation. So when you're ever giving a glucocorticoid and it is for inflammation, note also that you may be suppressing your patient's immune system. And if this is not the desired effect, it becomes an adverse effect. The effects on the immune system and inflammation are interrelated. So we're going to talk about them together. Let's review the process of inflammation. So the process of inflammation, we have pain, swelling, redness, and maybe warmth to the area. And this is all initiated and put into play by our prostaglandins, our histamines, and our leukotrienes. We call these chemical mediators. They become amplified by neutrophils and macrophages, remembering that those are variations of lymphocytes and phagocytic cells. Our prostaglandins and histamine also play a part in inflammation, and they can promote symptoms like swelling, redness, and the warmth that you're feeling. We have vasodilation and also increased capillary permeability. Remember that capillaries become leaky and spill out contents. Prostaglandins and histamine contribute to pain. Histamine will also stimulate pain receptors directly, and prostaglandins will synthesize that pain to stimulate or will synthesize the pain that is also being stimulated by histamine as well. So it's a compound effect. Neutrophils and macrophages will heighten this inflammation. We're going to have the release of lysosomal enzymes, and this is all going to cause injury to the tissue area. Let's focus now on the lymphocytes. Now, lymphocytes are important elements of our immune system. They will intensify inflammation by causing direct cell injury, but also they're doing this to promote the formation of antibodies that will help perpetuate the inflammatory response. Glucocorticoids will act on several mechanisms to interrupt the inflammatory response. So this is why glucocorticoids are helpful. They're going to inhibit the synthesis of those chemical mediators. Remember, those are prostaglandins, histamines, and leukotrienes. They're also going to reduce swelling, warmth, and redness, and also pain. Additionally, you're going to have a suppression of the phagocytic infiltration that is occurring in the site. So the damage from the lysosomal enzymes is pretty much averted due to the use of glucocorticoids. But also, we know that glucocorticoids suppress the proliferation of lymphocytes, and thereby it's going to reduce that immune component of inflammation. It's really cool that we appreciate how much glucocorticoids can actually help suppress inflammation. However, we also know that we can achieve some of this by the use of nonsteroidal anti-inflammatory drugs as well. And NSAIDs suppress inflammation primarily by inhibiting the prostaglandin production and inhibiting COX. Now, glucocorticoids share this mechanism. However, it's acting on inflammation in a little bit of a different way. And because they act by multiple mechanisms, glucocorticoids have much greater anti-inflammatory effects than NSAIDs. They are going to work better in terms of overall medication or pharmacologic effect. You're going to get more out of a glucocorticoid than you would an NSAID. Same principles apply though. You want to use the least amount of pharmacologic treatment as possible or as necessary. We're moving on to pharmacokinetics now, talking about the absorption, which really depends on the route of administration. And you're going to see in a further slide the different types of administrative routes. And absorption is going to depend on whether it was oral or an IM injection. Absorption of glucocorticoids that are through PO or oral administration is very rapid and complete. After an IM injection, the absorption is also rapid with the two types of glucocorticoid esters. They're rapid with sodium phosphates and sodium succinates. Slower with the other derivatives like acetates. And the absorption at the actual local site of injection. Let's say you're doing an intralesional injection, right at the lesion, you're injecting it there. This is going to be slower than at IM sites. The duration of action is really going to depend on the dose, the route, and the solubility of that particular glucocorticoid. And when administered orally or intravenously, the duration is also going to be determined by its half-life. With IM injections, you're thinking about the duration in terms of water solubility. Highly soluble preparations have a shorter duration. Less soluble preparations will have a higher duration. And for those glucocorticoids that are administered locally, that duration is going to be determined by solubility and the site of administration. So there's a little bit more variability there. Okay. So we've touched upon most of these different disease processes in other slides and lectures and discussions, but I do just want to touch on them really quickly in terms of how glucocorticoids specifically will help with this process. And so you're seeing with rheumatoid arthritis, it's really to help with the inflammation that occurs at the joint space. It's really cool also that in addition to just trying to give them a systemic glucocorticoid, we actually can offer intra-articular injections. And this can be advantageous because you can see that it's very effective and it's less, it has a less risk for toxicity than a systemic dose would. I have seen patients, it's very fulfilling to see that, they're in a lot of pain and they can't move that joint. You have them be treated with intra-articular injections and they're able to move without any pain. And they are very thankful for that. Although with lupus, even though this is very similar in rheumatoid arthritis presentation with inflammation, the inflammation here with lupus is not just in the joints, it's going to be systemic. And in addition to just the inflammation, patients with lupus also can suffer from pericarditis, pleuritis, and nephritis. And these things can actually be very fatal if not treated. Now, fortunately, the manifestation of lupus can also be controlled with prompt and aggressive glucocorticoid therapy. For inflammatory bowel diseases like ulcerative colitis and Crohn's disease, Glucocorticoids are very useful to help suppress this inflammatory process. It can be given orally or intravenously, and you have perhaps or will have perhaps get into ulcerative colitis and Crohn's disease in a little bit more detail in a further chapter. Overall, there's other inflammatory disorders like tendinitis, synovitis, bursitis, osteoarthritis, and even gouty arthritis. These all can be treated with glucocorticoids as well, because we're trying to reduce the inflammatory process. With allergic conditions like allergies or bee stings, not causing anaphylaxis, but just that irritation or inflammation that may be induced, glucocorticoids can be a drug to use. However, because there's a delay in the response, you wouldn't want to give it in lieu of epinephrine for anaphylaxis. For life-threatening allergic reactions, epinephrine remains the choice drug. We saw last week that glucocorticoids can be used effectively with asthma. They are one of the most effective anti-asthma agents actually that are available. We can give them orally, but perhaps try inhalation first, right? Remember, inhaled glucocorticoids. We want to do this because we need to reduce the serious toxicity that's associated with oral glucocorticoids. And actually, we wouldn't even want to offer oral glucocorticoids unless someone has not responded positively to all the different types of inhaled glucocorticoids, and perhaps you've even tried an inhaled cromolyn and it didn't work. Then you might consider a systemic dose of glucocorticoids. For skin, there's many things that it can help with. It can help with psoriasis, contact dermatitis. It can also help with seborrheic dermatitis and even some fungal type irritations or inflammation. Topical administration usually is enough for dermatologic issues. However, if you've already tried the topical approach and you've exhausted the time that the drug recommends for that use, then you can then move on to perhaps another topical. And if you've exhausted a few, then maybe go to an oral type systemic glucocorticoid. I really try not to use oral glucocorticoids for dermatologic issues if I don't need, right? If we don't need systemic therapy, then why use systemic therapy? Now, this isn't to say that topical glucocorticoids can be toxic. They definitely can be toxic as well. And this is why you need to further educate your patient on how much and how often they are using their topical glucocorticoids. We also use glucocorticoids for the prevention of RDS or respiratory distress syndrome in our premature babies. So if we know that a woman has a known risk for preterm labor and delivery, then by giving them glucocorticoids, we can actually help to mature or hasten or accelerate lung development in their fetus. And this is going to help them with gas exchange, lung mechanics, and also perhaps even with surfactant production. And this is given as a prophylactic or before delivery measure to the mom, and it gets passed to the fetus. The benefits get passed to the fetus. Unfortunately, though, there are many great ways to use glucocorticoids. This drug does have a large profile for adverse effects, and the intensity of these effects actually will increase with your dose size and also the duration of treatment. The effects are not seen. The ones that are listed here are not seen when dosage is low and you're only trying to get a physiologic response. Okay, so most are not seen when the treatment is brief or just within the few days. And this is something that you want to educate your patients on because they'll be very reluctant to take a steroid treatment because they've heard this to be true. Now, when the doses are high, it also is something where you may not see some of these adverse effects. So it's high doses plus duration treatment, the longer and higher. In combination, this is going to put you at higher risk for these following adverse effects. Now, osteoporosis is what we'll start with. We know that with osteoporosis, our patients are prone to fractures and other serious complications regarding their bone and bone health. And this is due to prolonged systemic glucocorticoid therapy. It's very uncommon that when glucocorticoids are inhaled or even administered topically, as an ointment or cream, that you're going to have issues with osteoporosis. Keep in mind, though, that it is a possibility, but it's going to be more frequent with the oral and IV preparations. In terms of what areas are going to be more affected, usually it's the rib areas and the vertebrae that are most affected by osteoporosis due to glucocorticoid. We've actually seen patients with compression fractures that of the vertebral spine that occur within weeks of use from glucocorticoid. So this is something to think about. It happens rarely, but if you are giving a very high dose and they're using it for a long time, please consider this. You want to observe for signs of compression fractures. So look at their back and the neck. Ask for them to report any pain or any changes around that rib area and their spinal cord. There are three primary causes that this happens, or osteoporosis happens. And the most important mechanism is because of the suppression of bone formation by osteoblasts. While glucocorticoids actually accelerate the bone resorption by the osteoclasts. So then glucocorticoids are going to reduce intestinal absorption of calcium as well, and this causes hypocalcemia. So in response to the hypocalcemia, what happens? PTH increases, so that's the release of parathyroid hormone, and then also the increase of mobilization of calcium from the bone occurs to offset this. So we're robbing the bone of calcium. With glucocorticoids, remember that it also has an immune suppressive response. So patients that are taking glucocorticoids have an increased susceptibility to infection. Especially the risk for acquiring a new infection increases. And also, if they've had a previous infection, we can actually reactivate a latent infection. So think about tuberculosis. Additionally, because suppression of both the immune system and neutrophils helps to reduce inflammation and other manifestations of infection, sometimes these things are happening and we can't even detect them very readily. So, glucocorticoids not only increase your susceptibility to infection, but also can mask the signs of infection and the progression of infection. With wound healing, the inflammatory response to injury is to provide inflammation. We've talked about this extensively. And glucocorticoids will interfere with normal inflammatory responses. But also, this can cause a delay of impairment to wound healing. Glucocorticoids should be used very judiciously with patients that are being managed for diabetes because their effects on glucose production can cause hyperglycemia. And glucocorticoids can increase the plasma glucose levels overall, causing hyperglycemia, but also glycosuria as well. When using high levels and high doses of glucocorticoid therapy, it can also cause myopathy and manifest as weakness. So you're thinking about arms and legs being the most affected. It's the peripheral. And damage to muscle can be sufficient enough to inhibit your patient's ability to ambulate. Fluid and electrolyte disturbances can also occur. We've talked about that sodium and water retention. So again, hypernatremia, edema, but we also can have hypokalemia due to the balance of potassium ions being lost. We also know that hypokalemia predisposes a patient to heart issues like dysrhythmias and toxicity from digitalis. And really, it is, though, something to consider that fortunately, most of the glucocorticoids that we use now have very minimal mineralocorticoid activity, meaning that most of the glucocorticoids that are approved and that we use readily aren't going to provide this type of fluid and electrolyte disturbance, but still be aware. You may have heard that glucocorticoids suppress growth in children, so we don't want to use glucocorticoid therapy if we don't have to, and this is more readily going to occur with systemic steroid use. And this is due to a reduced DNA synthesis and decreased cell division. Psychologic disturbances, these are one of probably the things that stand out to me the most. I actually had a patient in the ICU at a mental health facility. She was a educator, and she was on long dose and high dose glucocorticoids. And actually, she was admitted for psychologic disturbance. And so she had a psychosis due to systemic glucocorticoid use. About 60% of patients will experience a little bit of a mild reaction like insomnia, anxiety, agitation, or irritability. She was within the 6% that was experiencing a severe reaction. So, in that severe reaction, we're talking about things like delirium, hallucinations, euphoria, mania, and even can cause depression. Of this, up to 1/3 of this 6% of patients can also become suicidal. So, you do want to think about their psychiatric health and wellness in terms of, do they need this dose of systemic glucocorticoids? With cataracts and glaucoma, thinking about cataracts first, which is a common complication of long-term glucocorticoid therapy. So if they already have cataracts or they have a high risk for cataracts, I probably would try to find something different to use if it is available. Systemic glucocorticoids can also cause open-angle glaucoma, and what you might see is the onset of ocular hypertension developing too. It develops pretty rapidly, but as soon as you stop using the glucocorticoid, the patients will have a reversal of symptoms, usually within a couple weeks. Glucocorticoids have actions that lead to peptic ulcer disease as well, because remember, glucocorticoids can inhibit prostaglandin synthesis, and so thereby it's going to change the way that our gastric acid and pepsins are secreted. And if we inhibit the production of the cytoprotective mucus in our intestinal lining, it's going to reduce gastric mucosal blood flow. All of these things are going to predispose our patient to GI ulcerations. It also, because glucocorticoids can decrease gastric pain and inflammation, it can hide or disguise the symptoms. And maybe the patient will, have a GI ulceration and we won't know until a little bit later. And so as a result, this can result in perforation and hemorrhage without much warning, especially if they're using it in conjunction to NSAIDs that also have a high risk profile for the same reason. And we are putting them now at a double risk for GI ulceration. For Cushing's syndrome, a long-term glucocorticoid therapy can actually induce a Cushing-like syndrome. And so you'll have very identical symptoms with the natural occurring Cushing syndrome, which is an endocrine disorder. And so the things that you might see as prominent symptoms are hyperglycemia, glucosuria, so you have glucose in your urine. You will have the fluid and electrolyte disturbances, osteoporosis, muscle weakness, and you will have a lowered resistance to infection. Now, note that all of those things in this Cushing syndrome or Cushing-like syndrome, it's kind of the combination of all the other symptoms we've already talked about and discussed. Also, knowing that you'll see actual physical assessment changes, just like you would in the endocrine type Cushing syndrome. Redistribution of fat to the abdominal area, the face, the neck, and this is also going to produce central obesity and round face. We call that moon face. Fat pad on the cervical spine. These are all characteristics of Cushing syndrome or Cushing's disease. The development of adrenal suppression is something else we want to look out for, and perhaps it's one of the most dangerous adverse effects that can occur with long-term glucocorticoid therapy. So we want to make sure our patients are managed properly. So just like cortisol or other endogenous glucocorticoids, these glucocorticoids administered as a drug can suppress that negative feedback loop. So it can suppress the release of CRH from the hypothalamus, and it can also suppress ACTH from the anterior pituitary. By doing this long term, the pituitary is going to lose its ability to manufacture more ACTH. And then in response to that, we're going to not have enough ACTH. Our adrenal glands may become atrophied, and they're going to lose their overall ability to synthesize cortisol and other glucocorticoids in our body. So, what's the net result? With prolonged glucocorticoid therapy, we are now suppressing that feedback loop. So, how do we fix it? We need to stop the glucocorticoid. So, you want to discontinue it as soon as possible. However, you have to also think about how you're going to taper off. And we're going to get to that in a couple more slides. As a result, when prolonged glucocorticoid therapy is discontinued, there's going to be a period, though, in which the adrenal glands are still not able to produce glucocorticoids. They don't just ramp up quickly. It's going to take some time. And so subsequently, we're going to be in a period of adrenal insufficiency that can cause life-threatening symptoms to our patient. And knowing that each patient's response is going to be very highly individualized, we need to consider any patient that is receiving a pharmacologic dose of glucocorticoids for over 3 weeks, they're going to be probably the most at risk for adrenal suppression. Yet we know everyone's a little different. That's just kind of a rule of thumb, plus or minus some days. The time that's needed for our adrenal recovery is going to be very different and variable. Sometimes it's just up to 5 days, and now our adrenal glands are now able to reproduce glucocorticoids. And sometimes it can take some patients even up to a year. And so that extent of suppression that's occurring is also going to determine the time that is needed for recovery. Hopefully this scares you just a little bit to really consider the duration of glucocorticoid use and dosage size. Very, very important. Now think about why adrenal suppression is a problem. Now, in relation to our physiologic stress, we know that adrenal suppression is going to intensify the danger of physiologic stress on our body, even when we have glucocorticoid therapy. Remember that when stress occurs, our adrenal glands, usually if they're activated, they're going to secrete larger amounts of glucocorticoids than usual. But if the stress is sufficiently severe, like in trauma or surgery, the glucocorticoids are hopefully helping to support life during that time. But because of adrenal suppression, your patient's not able to do that. And so you have a patient that may be given increased doses at the times of stress. And this can help unless the dosage is already very, very high. Then you wouldn't want to give them a higher dose. So after glucocorticoid use has stopped, those supplemental doses may be required only in times of stress during the recovery until that adrenal function is complete. So it is a little bit of a taper, but it's also, using the glucocorticoid to help balance until you get full adrenal function again. Remembering again that it can be up to 5 days to even a year or more. Glucocorticoids do have some related interactions to other drugs. So if you're thinking about any other drug that a patient may have on their medication report that also is causing potassium loss, then glucocorticoids will start to exacerbate that as well. So think about it in terms of combining it with perhaps a medication like digoxin, because we know that hypokalemia is already there. We already have a risk of dig toxicity and dysrhythmias, and now they may have the potential for more potassium loss with the use of systemic glucocorticoids. Other things that you might consider is like the use of thiazides or loop diuretics. With non-steroidal anti-inflammatory drugs, again, working on the GI tract, so concurrent use of these drugs are contraindicated because you're increasing the risk for ulceration and bleeding. For patients that are on insulin or any other type of oral hypoglycemic medications, you want to remember that glucocorticoids actually promote increase of glucose in the serum, so hyperglycemia. So in order to maintain glycemic control with these patients, you may have to increase the doses of the glucose lowering drug. So if they're on insulin, you might have to increase their insulin. If they're on an oral hypoglycemic like a metformin, you might have to increase their metformin until their glucocorticoid therapy is complete. You wouldn't want to necessarily not consider glucocorticoid therapy because that may be the only thing that works for that patient. So think of someone that has a rheumatoid arthritis, but also they have diabetes, then there may not be another option. So consider it and weigh the benefits and the risks. Because of their immunosuppressant actions, glucocorticoids also can decrease antibody responses. So if you are given a live virus vaccine, the immunosuppressant action of glucocorticoids actually increases the risk of developing that disease and actually spreading it as well. And this is true with the live virus vaccinations. Glucocorticoids are contraindicated for patients with a systemic fungal infection or if they are receiving a live virus vaccine. You would not give them any type of glucocorticoid therapy. In terms of precautions with administration of glucocorticoids, especially with pediatrics and patients that are pregnant or breastfeeding, you're going to use extreme caution. Also, caution with patients that have hypertension, heart failure, renal impairment, GERD, peptic ulcer disease, diabetes, osteoporosis, open angle glaucoma, anything systemic like lupus, or maybe they already have Cushing's. So any of those type of patient profiles, you might want to consider another alternative if another alternative is available. And again, just reiterating again, the drugs that promote potassium depletion, you don't want to give those drugs along with glucocorticoid steroids. So we're going to get into the actual dosages here now. Again, remembering it's very individualized and even within patients with a similar disorder. So that dose has to be determined by trial and error. You always want to go slow and go low. Now, for patients whose disorders are not threatening to their life immediately, always go slow, right? There's no need to ramp up that quickly. And then you can go up when you're seeing effects of or benefits to the symptoms. Then you can find a sweet spot and then dose at that range and then decide how long the treatment course needs to be. However, in the event of something life-threatening, you might need a large loading dose or a large initial dose. And if a response does not occur rapidly, then you might even need to double that or triple that. When glucocorticoids are used for a long time, though, the dosage should be reduced until, again, you're moving backwards and until you are achieving that smallest effective amount. Remembering that glucocorticoids should be withdrawn if you are using them systemically over 2 to 3 weeks in high doses. The general guidelines for dosing glucocorticoids, fairly simple. Remembering that prolonged treatment with high doses can be dangerous, can be life-threatening, and potentially it can cause permanent disability. So you need to establish, what is that therapeutic objective in the first place? And perhaps it's not complete relief. Maybe that is not what can actually be done. It's not tangible. So think about this with your patient, and it's just reducing symptoms to an acceptable level rather than trying to achieve complete relief. And this can also help you to not overdose the duration or the dosage itself of the glucocorticoids. And we know that abrupt termination of long-term therapy can unmask adrenal insufficiency. And in order to reduce the effects of adrenal insufficiency, we need to make sure that the withdrawal of glucocorticoid therapy is very gradual and warn your patients against abrupt discontinuation of systemic glucocorticoids. The other thing I want to bring up before we go into more of the withdrawal is that there are some, in lieu of taking a dose of glucocorticoid every single day, you could do alternate day therapy. And with alternate day therapy, a large dose of an immediate acting glucocorticoid can be given every other morning. This is in contrast to what a traditional dose would look like multiple smaller doses administered daily, right? What's the benefit of doing this? First, we can help to reduce adrenal suppression, and we can also reduce the risk for growth delay and toxicity overall. And this is pretty effective too with our pediatric patients as well. Unfortunately, alternate day therapy does have some drawbacks. In the long interval between the doses, the levels can actually fall to subtherapeutic values and permitting the flare up of the symptoms. So, depending on how much you're giving and dosing in the first place and what those symptoms are, it may not be beneficial to alternate day therapy because then every other day the patient is dealing with the symptoms you're trying to get you're trying to manage in the first place. So, is that acceptable to your patient? That's a discussion for you to have with them. Now, going back to glucocorticoid withdrawal, it all has to do with recovery of the adrenal function. So, really try to understand how the adrenal gland plays a large role in the withdrawal process. We always have to withdraw long term high dose glucocorticoids. They need to be done slowly, withdrawal slowly. And the withdrawal schedule is determined by the degree of adrenal suppression. Somebody that is on a glucocorticoid for a long time in high doses needs to usually taper the dosage to a physiologic range over 7 days, meaning that over the course of 7 days, we are bringing it from high dose pharmacologic treatment to low dose physiologic treatment within a week. And then we're going to switch from multiple day doses to single day doses in the morning. And after we've done that, the third step is to taper the dosage by 50% of the physiologic value within the next month. And while we're doing this, we're monitoring for the production of the body's own endogenous cortisol. And once those basal levels of endogenous cortisol are normal, then we can stop the tapering and discontinue the glucocorticoid dosing. So as a rule, tapering is unnecessary if you're using oral glucocorticoids for less than 2 to 3 weeks. If you used it over 3 weeks, then you're going to start this again. You're tapering the dosage down to a low dose for 7 days. Then you're going to go and switch that to multiple day dosing down to once a day. And then you're going to bring it even down to 50% for the next month. Okay, so very important detail here, anything over 2 to 3 weeks. Additionally, to unmask or to deal with this unmasking of the adrenal insufficiency, if we stop glucocorticoids, it can actually produce withdrawal symptoms. And what are the withdrawal symptoms that we might see? We'll note that there's adrenal insufficiency, but what we're going to see manifested is hypotension, hypoglycemia. We'll have patients complain of fatigue, myalgia, and arthralgia. If patients are being treated for arthritis or other types of arthritic disorders, you might be very confused about the symptoms. And, really you're thinking about the underlying disease at this point. How do you lower the rate of discomfort or experience of discomfort from withdrawal? You want to do gradual dosage reduction. I don't usually spend that much time on routes of administration during our pharmacology lectures, but I think that it's relatively important, at least to recognize which systemic glucocorticoids are short acting, immediate acting, and long acting. And this is all depending on their biologic half life, also the potency, and not only the mineralocorticoid potency, but also you're looking for the glucocorticoid potency. Remember, that is how anti inflammatory is this medication. So, when we're using drugs with a higher mineralocorticoid potency, these are the cortisones and the hydrocortisones. And these drugs have more significant retention of sodium and water and depletion of sodium. So here, those symptoms, that triad of symptoms, is related to cortisone and hydrocortisone more than the other type drugs. And this is going to be hazardous for patients that are on other drugs that retain sodium and cause potassium loss. So we talked about those earlier. As a reminder, that can be DIG, and it could be some of your diuretics. For the routes of administrations, we know that we have oral forms. We also have parenteral or IM and sub-Q forms as well. Topical, intranasal, and injections. Remember, we use the intra-articular injections for our patients that may have arthritis. We're going right into the joint space. And then also for asthma, we're using inhaled glucocorticoids. The topical applications for glucocorticoids we've discussed earlier when we looked over skin disorders. And then, of course, for asthma and allergic rhinitis, we've discussed those as well. So go back and look at those charts for intranasal inhalation and topical steroids. Okay, we're nearing the end of this presentation. We need to discuss patient education and then lifespan consideration. So first, with patient education, make sure their patient is taking in the morning. The reason for this is that this is when your own body is naturally producing these hormones. So you want to keep it on, or try to keep it on, the natural physiologic timing. Also, to reduce the GI distress, you may want to administer with milk or a snack, so not on an empty stomach. And this is true for the PO um, treatment. Also, warn your patient not to abruptly discontinue their therapy without talking to a medical provider, especially if their therapy is high or prolonged. Again, remembering that 2 to 3 weeks sweet spot. Adrenal suppression is life threatening. So, those withdrawal symptoms are also going to be an indicator. And as soon as they are having any of those symptoms, they need to contact you as the provider or go into the emergency department or urgent care. It may be advisable for patients that perhaps have lupus or rheumatoid arthritis and they have these chronic disorders and they're using steroid treatments. Think about a Crohn's patient. They might need a medical alert bracelet so that it can be properly recognized in any type of emergency, so that knowing that their body is already receiving glucocorticoids every day. But also remember, during stress responses, your body makes even more glucocorticoids. So knowing this will help to explain what may be going on and help direct the treatment for this patient. You also want to tell your patient that it's great for anti-inflammatory reasons, but it also can increase your risk for infection because it suppresses your immune system. And they may not even know or get to see those early signs of infection, but teach them anyways, fever, malaise, have them call you. If there's any sign of fluid retention, weight gain, swelling, have them call you. What about the signs for low potassium, muscle weakness, pulses that are irregular or cramping? Have them call you as well. They need to develop a plan as soon as possible and perhaps stop the glucocorticoid, again, knowing that these don't readily happen when we are using these drugs for a pharmacologic dose. And to decrease the risk of cataracts and glaucoma, reinforce the need for eye exams during the course of therapies or periods of therapy. And if for whatever reason their vision is cloudy or blurred, they need to report that also. Any signs of GI bleeding, upper or lower GI bleeding, you want to report that and make sure you remind them to avoid any over the counter drug that can have a potential effect with their glucocorticoids. For me, if they want to use anything over the counter that hasn't already been looked at during our appointment, then I have them call me or call the nurse line before buying anything. And then lastly, I want to inform them to look at their stools as well because they may not recognize that that darkened stool or that black tarry stool is indicative of a GI bleed. Look for physiologic reactions, but also don't forget there is a psychologic component, right? So if they're having any disturbance in mood, um, you will want them to call you as well, and you might need to change the management of their medication. I'd also advise you to discuss this with their family member or support system because it may not be the patient that recognizes these psychologic symptoms first. Last slide has to do with patient-centered care across the lifespan. We remember here, so this should be a review for you mostly. Long-term use of steroid medications inhibit bone growth and also can decrease the stature of the patient. Using glucocorticoids during childhood can increase the risk for lifetime osteoporosis as well. There is inadequate studies for pregnant women in terms of pharmacologic dosing of glucocorticoids. However, animal studies have shown that they can be not only teratogenic, but also cause physiologic effects. During the first trimester, it can contribute to cleft palate. Later on during the pregnancy, it can also cause hypoadrenalism. But for some conditions, like patients with severe persistent asthma, the risk is not there. Can be more, or excuse me, the risk of not using the inhaled glucocorticoid steroid can be more harmful to them because they're not able to breathe, right? So it needs to be balanced as well. So weigh the risk and the benefits and use it with the shortest shortest period of dosing and the smallest dose also to control the symptoms. And then the last thing to think about is that if you do need a systemic glucocorticoid during pregnancy, then hydrocortisone is the preferred glucocorticoid over the others. For breastfeeding women, when physiologic doses or low doses are used, the concentration is too low to really affect the nursing infant. However, large pharmacologic doses can cause sufficient growth delay as well to our breastfeeding babies. For our older adults, remembering that long-term use can cause osteoporosis, adrenal insufficiency, and GI ulceration. So make sure that you are thinking about that. These conditions affect older adults disproportionately to our younger population. So for sure, those three things you are going to monitor in patients using glucocorticoids.